Scenario 3 is in the intensive care environment. Just pause there and just give you a bit of an overview of what this case is about. This case has two potential outcomes. The scenario still starts with Anthony DeBuzzy, and he is in the intensive care. However, we have a standard route, which is the patient is worked as a team to prone the patient, and this happens successfully and there is no major complications to the patient. However, we have an alternate route, and in the alternate route scenario, we would need a confederate at the head, and as they roll the patient over, the confederate would also extubate the patient, and then the team would have to return the patient to a supine position and insert the ETC again. This is an alternate route if that's what is required at your place of work. But so far what we've heard is that some people aren't comfortable with the proning process with a lot of new people coming to the intensive care. So how wonderful would it be to have an opportunity to practice proning prior to actually having a COVID-19 unwell patient in the environment? It is interesting to note also that we have checked with the field service engineer team at Laerdal Medical to make sure that we can prone the patient successfully, as the ASL monitor diverts the air from the lungs and out through to the ASL monitor. The only part of the chest that rises is the chest rise and fall bladders. These are okay to be rising even when you are proning the patient, as long as you place pillows down underneath the chest when you prone that patient in the scenario. Let's go over the learner brief. The learner brief we recommend to be read out to the participants. As I said earlier, you can change it if you would like to. It's now day 2 of this patient's condition. It's 8 o'clock at night and they're in the intensive care. The situation is your patient is Anthony DeBuzzy. He's a 71-year-old male who was diagnosed with COVID-19 2 days ago. The patient was transferred to the intensive care unit and has been paralysed and sedated to improve his ventilations. Last hour or so, the patient deteriorated and the team was considering proning of the patient. Background: the patient has a past history of non-insulin requiring diabetes and chronic kidney disease. Neurologically, the patient was sedated and was given vecuronium about an hour ago. Cardiovascularly, the patient is tachycardic, hypertensive, febrile at 39 degrees, pale at the peripheries with a CVP of 8. ETT is 7.5, 22 centimetres at the lip. Volume control assist, rate ventilated at 20 breaths per minute. Tidal volumes of 420, targeted tidal volumes of 420, peak of 10, flow trigger of 3. He does have some secretions when suctioning. The nasogastric feeding has been stopped and it's now on free drainage. Bowel sounds are present. IDC is draining roughly 40 mils an hour and intravenous therapy is 42 mils per hour. Skin, there's no pressure breaks noted and all lines are secured and 2 days old. Recommendation: please go and assess the patient and perform interventions to improve ventilation status of the patient. We have listed a different lot of learning objectives related to this case, such as still applying the PPE but performing a primary assessment of the patient, realise the need for turning of the patient to the prone position, verify sedation and paralysis prior to changing the person's position, delegate roles, communicate effectively as a team, perform the turning of a sedated and paralysed patient, and doff the PPE. The equipment list is listed below is very similar to the equipment list in case number 2. The list is by no means exhaustive. It does not have every last thing, but it's a guide to at least get you started with the scenario. We will need extra pillows for this scenario to go successfully. The scenario was designed for 3G, mystic, trauma, essential and essential bleeding. Jess, did you want to explain about the lung model?
Thanks, Amy. Yeah, so in this third scenario that we're showing you for the prone patient. The patient is sedated and paralyzed, and we will prone them. There is only one lung model in this one, just because it's more geared towards the actual act of proning. So we just have the sedated and paralyzed model here.
Thanks. So once again, we're going to start by connecting the ASL in the bottom left-hand corner. By pressing play when it starts simulating, it also starts the case. We're prompted with the ASL lung model requirements and also some desired or recommended vent settings. As we come close to starting the scenario, participants will be able to apply the PPE, and as a group, hopefully they could apply their PPE in the correct order. As we move into the patient care, we still have introduce self, assess level of consciousness, assess breathing, assess pain. As we complete the primary assessment, we're preparing our patient also for that proning position. So making sure all our lines are secured, check our ventilator settings, ensure that we've done a full assessment prior to turning the patient over onto prone position. A big element of this scenario is obviously communicating effectively as a team. Just pause there for a moment. The important factor is obviously making sure that we have ensure that there's no contraindications for prone positioning, and also that the team as a whole understands how they're going to move the patient into the prone position. So identifying the airway lead, identifying turning positions and receiving positions helps to communicate effectively as a team. It's a clinical decision whether or not increased sedation or medication is given, and either you can or you don't need to in the scenario. That's your choice at your local area based on the handover. Let's just give a bit of midazolam. So once the team is satisfied, they can confirm that the sedation is in, and they can also give maybe some vecuronium for the case. As they start the turning of the patient, they will see artefact on the ECG. There's two options here, the green.
So, oh yeah, I'll let Amy finish here.
Sorry, thank you. So there's two options there, patients turn successfully, or optional route, patient accidentally extubated. That is that extra route, the red button, if you choose to go that way in the scenario. Sorry, Jess.
Once again, we're looking at the vent screen here. So the patient is sedated and paralyzed and receiving all controlled breaths. The rate is set at 25 to try to normalize the CO2. And our peak pressures are within an acceptable range for this particular disease state and the severity of it. Since this is right after the initial proning, you won't really see an immediate change in peak pressures from an improvement in compliance. And you will actually most likely see a drop in saturations with a slow increase over time just from the proning, the actual physical proning of the patient.
So here on the patient monitor screen, you see prior to us moving the patient into the prone position, a normal ECG trace. Obviously the oxygen saturations are low and CO2 is high. But as we go into the prone position movement, you will see artefact on the ECG. As proning can cause some hemodynamic instability, we have built a little bit of a trend at this point so that you can see some changes to the hemodynamics so that people are reassessing and reevaluating their patient. Once we click off patient turn successfully, there is that slight moment of some hemodynamic instability, and we're not looking for a rapid change or rapid improvement. It's, as Jess said, something that happens over a period of time. As they're going through the scenario, they would most likely do another reassessment of the patient to see how they're stabilising after the movement of the patient. If they choose to show the X-ray, that will show up also on the patient monitor. Then after the scenario, they have the option to doff and remove any of the single-use items from the area. You'll notice that when we built these scenarios, we built them with some consistency across the three, because we understand at this time we want scenarios that are functional, but also allow you to have an opportunity to follow a patient through the COVID-19 experience. As we go to debrief this time, let's have a look at the debrief file of what it would look like in SimCapture. You'll notice that along the timeline at the bottom, we can see all those events and we can highlight a particular event and go to that particular moment in care. As you can see, we've intubated this patient and we haven't secured the tube. That might be worthwhile bringing up in the debrief file. We also have the hemodynamics displayed in the bottom if we want to look to a particular moment in the care.
Okay, thank you so much, Amy and Jessica, for sharing your insights and leading us through the demonstration of those scenarios through the ASL 5000 lung solution. We hope that through this webinar, we have provided you with information and tools that you need to prepare to keep both personnel and patients safe under the current crisis conditions, ultimately to help save more lives together.